Hello everyone and welcome to my YouTube channel. In today's video, we'll be seeing another topic, that is spina bifida. Now, in general, spina bifida is a disease of the spine, that is your spinal cord and the vertebral column. Now, before we head into this topic, let's see how the spinal cord and the vertebral column is formed. Now, neurulation. Neurulation is nothing but the process of formation of the spinal cord and the vertebral column and the brain. Okay, so the entire process is called as neurulation, and any defect or any abnormality in this process leads to neural tube defects. And neural tube defects can lead to different diseases, in that one of which is spina bifida. Now, this process begins at the third week of gestation. So please remember this and keep this, remember this point, that neurulation begins at the third week of gestation. This is important. Now, if you see neurulation, one important part is the formation of neural tube. Now, neural tube is a precursor, or you can say it's the first step of formation of the brain and the spinal cord. And any defect in this leads to the neural tube defect. So as we saw, in the lower portion, if there's any defect, it can lead to spina bifida, and in the upper region, it can lead to a brain defect, which is anencephaly. Okay, so these are the most common neural tube defects, and today we'll be seeing spina bifida. Now, if we see the process in specific, let us look at our embryo. So this is the embryo, and this is the dorsal surface, or the posterior surface, or the behind. Okay, so as we saw that it develops starts at the third week. So at the posterior surface or dorsal surface, a groove develops here. You can see here a groove develops. So imagine the embryo to be like a plain sheet of paper. Now, if you want to make a tube out of this plain sheet, first a groove develops. Okay, and in the embryo, this particular groove is called as the neural groove. So this is the beginning of the formation of the neural tube. Now, to form a entire tube, these ends of the groove actually they meet, or they join together, and they form the tube. Okay, so as you can see in the pictures, the groove develops, and then these folds, or the ends, they meet, and then they form a tube. Okay, so the folding starts from the middle, as you can see in the picture, and then this folding continues upwards and downwards. So by the end of day 24, we can see that the folding is still progressing. So it starts in the middle, and then this forms your upper end, or which is called as a cranial neuropore, and this forms the lower end, which is called a caudal neuropore. Okay. So if you see the entire process in a single picture, first a groove is formed, then it starts folding, folds further, and then at the end it forms a complete tube. Okay, so if you see a cross-section view, also a groove is formed, and then it folds to form a tube, and this is a completely formed tube. Now, in front of this particular tube, there is another structure which is called as a notochord. Okay, so this particular neural tube, okay, this leads to the formation of the spinal cord, which is the nervous tissue, or the tissue that runs from one end to the other end of the vertebral column, and on the top it forms a brain. So this neural tube forms the spinal cord, and this particular structure here, which is called the notochord. Okay, so as we know that our spinal cord is protected within the vertebral column, so the vertebral column is formed from this part, notochord. Okay, so you have cartilages that start in the form of projections on either side. They grow, and ultimately they grow completely on either sides, and then they join to form the spinous process in a way to completely surround the neural tube of the spinal cord. So this is how from here a vertebral body, or a vertebra is formed. Okay, so uh, till now we just saw how the spinal cord and the vertebral column is formed. Now, if we see the definition of spina bifida, it goes by it's a congenital defect in the posterior bony wall of the spinal canal involving the lamina. So basically what happens here is, it is a defect. The vertebral body is usually formed but the defect is usually in this part, the arches and the lamina. Okay, so this part there will be a defect. Okay, and this defect is commonly seen in the lumbosacral region, and because of this defect, it's obvious that if there is a defect or if there's a hole, the contents may protrude or they may escape. So revising again, it is a congenital defect in the posterior bony wall of the spinal canal involving the laminae, and this is commonly seen in the lumbosacral region, and contents of the canal may protrude. Now, why it is seen in the lumbosacral region, as we saw here, the folding starts taking place in the thoracic region first. Okay, you can approximately say that this is the thoracic region, and this folding goes upwards and downwards. Okay, so usually, if there's any defect, it usually takes place towards the end of this process, and that's why either the lower end or the upper end is usually involved. So the lower end corresponds to the lumbosacral region. Yeah, this we just saw. Now, what are the risk factors for this particular disease? Now, nutrition status of the mother here. Okay, so basically, this is a disease of children, or usually seen in the younger age group. So, nutrition status of the mother is important. The folic acid deficiency, environmental toxins, obesity, diabetes, and genetic predisposition. Now, as we had discussed, or we had seen that this process of neurulation takes place around the third week of gestation. Now, why it is important here is, see, usually what happens is within first month of pregnancy, not everyone gets to know that they're pregnant. So they don't start taking supplements, or they don't improve their diet or nutrition. And we very well know that for the formation of the neural tube or the nervous tissue, folic acid is a very important nutrient. So most of the times, if the nutrition is poor, if there's no supplementation of folic acid, this can lead to the defect or abnormality in the neurulation process. Okay, so very important, and this usually is seen in the third world countries because generally their nutrition is at a lower level, and with pregnancy, which is a high demanding state where the body requires more nutrients, and where there's no change in the nutrition, this is very common in the third world countries. Okay, so this is also very important. Please remember this. Now let's see the types of spina bifida. So the first variety is spina bifida occulta. Then you have the meningocele, meningomyelocele, syringomyelocele, and the myelocele. Now, if you see the most common type, actually here is the myelocele. But in myelocele, what happens? The child usually doesn't survive, and there's a stillbirth. So the it is not, I mean, it's supposed to be the most common, but since the child is not alive, you have the spina bifida, which is the most commonest type. After that, you have the meningomyelocele. So myelocele is the most common, but if the child is not born, that's why it's not taken into consideration. After that, you have the meningomyelocele, which is very common. Now let us see each type in brief. So what happens in spina bifida occulta is here the defect, okay, the defect in the bony wall or in the vertebra is very minimum. Maybe just one vertebra is involved, and even the defect is not very big. So what happens here? There is no protrusion or there is no escape of the contents. That is the spinal cord and the membranes. That is the meninges. They stay within the vertebral column. Now, but some things that can be seen at the local place or the local part is there may be a patch of hair, there may be a lipoma, or sometimes depression may be, felt, which could suggest that there is some underlying bone deficiency. But usually there is no symptoms, usually symptomless, and this is what do you say? It is diagnosed accidentally. Yeah, there may be a presentation like this. There may be a small patch of hair, and there may be some kind of discoloration that can be seen, or depression. Now, there's one problem here. Now, since there's a gap, usually it is covered by a fibrous tissue, and this is called membrana reunions. And basically, this connects with the skin. I mean, this attaches the skin and attaches to the spinal theca, that is the covering of the spinal cord. Now, as we know that the spinal cord and the vertebral column are not equal in length, that is, maybe at the time of birth, the spinal cord is present at the maybe at the third level, third lumbar vertebra, and as the child grows, the vertebral column grows, I mean, keeps on growing, but the spinal cord, just remains at that same level. So the spinal cord may reach at the level of the first lumbar. Okay, so as you can imagine here, if there's a connection between the spinal cord and the vertebra, and if the vertebra keeps growing and the spinal cord, stops here, it kind of creates a pull. Okay, because of this membrana reunions that is attaching the spinal cord and the skin. Okay, so the boy keeps growing, the body keeps growing, but the spinal cord remains there, and this creates a pull. And because of this, you may see some neurological deficiency like your foot drop, your nocturnal paralysis, or some kind of backache. And sometimes there may be some local, sensory disturbances as well. But usually it is some asymptomatic or symptomless and diagnosed by accident. That is, the patient may have some other complaint, but on investigation, this is found by mistake. So clinical features, if you see, this is usually present from birth, and as we saw, there can be a dimple or depression, a local patch of hair or lipoma, and manifestations can include backache, enuresis, and local anesthesia, local paresis, that is weakness, and foot drop. And on the X-ray, this bone defect can be visualized. Okay. Now coming to the next part, the next type of spinal bifida is the meningocele. Okay, now here what happens is the defect can be a little bigger, and because the defect is bigger, what happens here is here the meninges may protrude out. Okay, so as we know, in the meninges you have within the meninges you have your CSF fluid. Okay, so you can see here the subarachnoid space that contains a CSF. So if the meninges protrude, the fluid within the meninges also kind of escapes with the meninges. Okay, because of which there can be a cystic appearance. Okay, or the swelling, cystic swelling may be seen at the site, and this is usually seen at the lumbosacral region, and usually the cystic swelling is covered by skin. Okay, so there is no problem in the skin, it's just that there's a local cystic swelling. So this is the meningocele. Now it can appear like this. And if you see yeah, again, another picture, we can see that the spinal cord remains within, but the meninges along with the CSF is kind of escapes or protrudes out. Now, if you see the clinical features, again, this is present since birth, and as we know, it is a cystic swelling because it's just a fluid-filled swelling. Now, fluctuation test is positive. That is, if you kind of hold the swelling, it moves around. So that is fluctuation test. Translucent swelling. That is, if you if you project light, the it absorbs the light and it gives the appearance. So that is translucent. Compressible is if you put up little pressure, the swelling may reduce. And expansile impulse, so that is when on coughing or anything like that, the impulse can be felt. If you place your hand over it, the impulse can be felt. And overlying skin is normal and it is free, it is not attached to the swelling, it is free. If you pinch the skin kind of separates from the swelling. And this particular defect, okay, if it is associated with hydrocephalus, it is called as Arnold-Chiari malformation. Now, as simple, the complication, it can, it can get infected or can also get ruptured. So this is your meningocele. Next we see is meningomyelocele. Now, meningomyelocele, here what happens, the defect may be a little larger when compared to meningocele. So here maybe three vertebra may be involved, because of which the meninges along with the CSF protrudes, but here there is an additional thing that comes out, and that is your spinal cord or the chorda equina. So these three things, that is the spinal cord, the CSF, and the meninges, they protrude outside. Okay, and yeah, it may appear like this. So it may appear larger than a meningocele, and if you see the picture here, you can see the meninges, and you can also see that the spinal cord is kind of coming out, and you have your CSF also. Now, since the swelling is bigger, it kind of stretches the skin over, and that's why on the topmost or the summit of the swelling, the skin may be thin or the skin may be absent here. Okay. Now, as we saw earlier, this is a very common variety. It is more common. I mean, after the myelocele, this comes next. Meningomyelocele. Yeah, meningomyelocele. Okay, so this is also a very common variety, and it appears like this. Now, clinical features, as we saw, again, this is a very common variety. Yeah, it's a commonest variety, and as I told you earlier, the three or more vertebra or segments may be defective, because of which the contents protrude. Okay, and if the skin is very thin or the skin is absent, you can actually see the meninges. Okay, and here infections and rupture is more common, as you know the skin covering is not seen, or it is very thin. And on translamination test, if you do, the nerves also may be seen here. And one more very important thing is the neurological manifestations are present. So in the previous variety, that is your meningocele, the neurological manifestations are not very common, but in the meningomyelocele, the neurological manifestations are definitely present. This is one of the way to differentiate meningomyelocele with the meningocele. Okay, so here you have the manifestations may include some sensory disturbances, some motor disturbances, and which sometimes it can lead to paresis or a complete paralysis of the legs. And the patient may also have bilateral talipes. Talipes is nothing but your club foot. Okay, so the club foot may also be seen, and urinary incontinence. Now, why urinary incontinence? Because as you know, the lumbar and the sacral region of the spinal nerve roots or the spinal nerves are responsible for controlling your pelvic organs, which includes your kidney and so not the kidney, the bladder basically. So this can cause urinary incontinence. And if you see the X-ray, there may be some other problems as well. There may be scoliosis, there may be kyphosis, and there may be a hemivertebra. Okay, so this is very important. Just remember that this has the neurological manifestations, and in this, the meninges, spinal cord, the CSF, everything protrudes outside. Whereas in the meningocele, it's only the meninges with the CSF. Okay, and again, infection and rupture is common. Now, if you see the prognosis again, yeah, same thing. There may be infection, the sac may rupture, and there may be some adhesions, and this has more of the neurological manifestations. Next variety we see is the syringomyelocele. Now, syringomyelocele here, the problem is in the spinal central canal of the spinal cord. Now, let's go back to this particular picture. If you can see this particular point, okay, this is the central canal. Now, this central canal is nothing but the neural tube lumen. That is, uh, yeah, the this particular lumen of the neural tube, it continues, or in future, in the later stages of the life, this particular lumen continues as a central canal. Okay, so in the syringomyelocele, the problem is with the central canal. So yeah, this particular thing, it just kind of blocks, and this increases in size. Okay, the central canal of the spinal cord is dilated. One more thing I want to tell you is here the central canal consists of the CSF. Okay, so if there's any kind of obstruction in the passage of CSF, this can lead to the syringomyelocele, and I mean it leads to the dilation of the central canal. And here neurological manifestations and paralysis is seen. Next, moving on to myelocele. Now, this is a very grave form, and it's a very gross form of spina bifida. Gross in the sense it's there's a lot of physically, if you see morphologically, there are a lot of defects that can be observed here. Okay, so what happens is till now we've been seeing that there's only a bony defect in all the different varieties of the spina bifida, that is the occulta, the meningomyelocele, the meningocele. There's only a defect in the bony wall or the vertebral column. Now here there is a defect in the spinal cord as well. So basically what happens here is in during the neurulation process, okay, during the neurulation process, where let's go back to this picture. Uh, so what happens here, this particular portion, um, the anterior aspect is anyway, this anterior aspect is formed, but the posterior aspect, before it folds or before it kind of fuses, okay, the development or the process is halted. Okay, so maybe at this level the development is halted. Okay, so because of which, one, the vertebral column is not formed, as well as the posterior part of the spinal cord is not formed. Okay, now because of which the entire the lesion, not the lesion, the entire place or the entire site appears very raw. Okay, and you can see that a lot of CSF fluid keeps on just kind of draining, and the anterior aspect is anyway formed, but the posterior aspect is, it looks very incomplete. Okay, so everything is just kind of open here, and usually the child doesn't survive, and it's a stillbirth. Okay, and even if the child somehow is born, it doesn't really live for many days. It dies very soon. So this is the most gravest form. Yeah. So I could not get in picture exactly of the how it looks in real. So here you can see that the vertebral body is formed. Some part of the anterior spinal cord is formed, but you know your posterior part of the spinal cord is not formed here. Okay. If you look at this particular picture again, maybe this till here it's formed, and here in the spinal cord also this portion may be formed, but after this the development just stops, and then the raw flesh or the raw nervous tissue is exposed, and the central canal also kind of keeps draining. So it's the most gravest form, and it usually leads to death. So to summarize, spina bifida is a disease of the spine, and it is because of a neural tube defect, that is any abnormality or defect in the formation of the spinal cord and the vertebral column. And you have different types based on how extensive the defect is. If the defect is very small, it is a spina bifida occulta, where there's no protrusion of any meninges or spinal cord. Then you have the meningocele, where the defect is a little bigger, but only the spinal cord, no, I'm sorry, only the meninges, kind of protrudes along with the CSF. Next, you have the meningomyelocele, where you have the meninges, the spinal cord, and the CSF protruding out. And then you have the myelocele. Myelocele is the type where there is incomplete development of both the vertebral column as well as the spinal cord. So with this, we come to this end of today's video, and thank you for watching.